Good evening, everybody. We today evening's topic is going to be fever in neurocritical care. So, Dr. Hari Prasad will be presenting case-based discussion. Let's start with it. Hari, you can start.
Yeah. Good evening. Good evening, everyone. Uh, Today we are going to discuss about the most important topic in neuro ICU. Most of the patients, the 70% of the patients admitted in our ICU will be encountering with fever. It is very difficult to distinguish between infectious and non-infectious. We'll be going into case presentation. Uh, 34 years old gentleman presented to our hospital with alleged history of road traffic accident on 22nd November 2025 around 9 p.m. near Coimbatore. Sustained injury to head, had LOZ, no history of vomiting or witness seizures, and ENT bleed. He was initially taken to our satellite center.
PB நினைக்கிறேன்.
He was initially taken to a satellite center, and at presentation to the emergency, his GCS was around E1, V2, M1. Vital pupils were not reacting to light, and the blood pressures were 90 by 60 millimeters of mercury. E first, which was done, it was negative, and he was intubated and ventilated in view of low GCS, and whole body CT was done in in that satellite center, which showed right FTP subdural hematoma with a midline shift of 6 millimeters, and was referred to our main center. On arrival to EMR, he was protected with 7.5 size subglottic tube, which was fixed at 21 centimeters, and controlled ventilation with minimal FiO2, targeting saturation more than 96. And vitals were stable, ma'am. Heart rate was 87 and blood pressures were okay. There was no significant past history in the past. He was occasionally alcoholic. And the CT brain, which was done in the outside hospital, was showing right FTP subdural hematoma with the midline shift and mass effect. And he was immediately taken up for neuroprotective measures were adopted in emergency with head and elevation to 20 degrees and neutral head position with sedation with fentanyl and muscle relaxant was started. And the basic blood parameters includes coagulation parameters and blood grouping and cross matching was done. The diagnosis was road traffic accident with isolated severe traumatic brain injury with acute right FTP SDH with midline shift and mass effect. He was immediately taken up for decompressive craniectomy and subdural hematoma evacuation. Introp findings are dura was bulging, tense with bluish discoloration, and STH was evacuated. Post procedure, the brain was lax and pulsatile at the end. Post-operatively, patient was shifted to ICU. On arrival, patient was under sedation relaxant. Pupils were right side 2 mm not reacting and left side was 4 mm not reacting. He was hypothermic. The temperature to prevent hypothermia preventive measures were adopted, and he was in, blood pressures were 100 by 60 with 0.2 mics of noradrenaline per kg per minute. Uncontrolled ventilation. Post-operatively, brain parenchyma was lax and follow-up CT was done following morning, 6 hours later. Antiedema measures were continued with hypotonic saline, and neuromonitoring was done in our ICU with hourly assessment of pupils, and ONSD measurement were hourly followed for first 6 hours, then on each shift basis. ICP was monitored with frequent clinical examinations and followed by CT scans aided with by ONSD. Blood pressure was maintained throughout ICU stay with target maintaining of target maintaining adequate cerebral perfusion pressure. In view of satisfactory status, after 24 hours, uh, his GCS was assessed, which was E2, VT, and M4 response. Pupils were bilateral 2 SR, sluggishly reacting, and ONSD was also satisfactory. Neuroprotective measures were continued. This was the post-operative CT, which was done next day morning, which shows the complete evacuation of STH, and midline shift was also been significantly reduced, and mass effect was there, but subdural hygroma collection was there with pneumocephalus minimal. Fluid maintenance was given with NS for maintenance with aim to maintain euvolemia during the stay in ICU. There were no episodes of hypotension during the ICU stay. Initial noradrenaline was weaned off in uh, 3 to 4 hours. Enteral nutrition was initiated on POD1 and target nutrition was achieved on day 5 of ICU admission with the following goals of 25 kilocalories per kg and protein of 1.8 grams per kg. The glycemic controls were the target sugars were incidentally his HbA1c was found to be around 11 and he was requiring insulin for maintenance and sugars were maintained between 180 to 140 to 180 milligram per deciliter. And initially on day 1 injection levetiracetam 500 mg IV 1230 was started for seizure prophylaxis. He did not have any seizure during the stay, hence was discontinued on POD 8. Conventional lung protective ventilation was carried out with tidal volume of 6 ml per kg and PEEP of 5 and EtCO2 of targeting around 30 to 35. On day 3, patient developed fever around 102 and antipyretics were started. After thorough clinical examination from head to toe, uh, the central lines were also less than 48 hours. So the basic evaluation was done with TCDC, CRP, urine complete was sent. And total counts were found to be around 11,300 and CRP was around 65. Urine complete came to be normal. On day 4, to facilitate weaning, percutaneous tracheostomy was done, which was uneventful. Again, on day 5, patient was having persisting fever more than 102.5 degrees Fahrenheit. And he had a GCS drop also from withdrawal to extension. Uh, Pupils were equally reacting, and follow-up CT brain was done on that day in view of GCS drop, which showed no significant changes. Again, on day 5, the basic blood parameters along with procalcitonin, two set of blood cultures were drawn. Urine complete was done again. Chest X-ray was done, which doesn't show any new infiltrates. Neck stiffness was present. So we have after withdrawing cultures, we have started on broad spectrum antibiotics and CSF analysis was done. And the reports were like WBC was around 100 cells, protein was little bit elevated, and sugars were normal. The CSF sugars were around 86, and corresponding sugars were around 182. Lactate was also around lactate was little bit elevated, around 37.8. Surgical site was also clean. There was no discharge or any infection was there in surgical site. DVT screening was done, which was turned out to be negative. Thrombophlebitis, sinus evaluation, thyroid profile evaluation was also done, which was normal. Cortisol levels were found to be normal. Drug chart has been reviewed. Uh, any drugs causing fever have been ruled out, and ultrasound abdomen was also done, which was normal. And the cultures which have been sent uh, turned out to be negative. The reason for infectious and non-infectious causes have been ruled out. So the probability of central fever can be considered.
Hold on here, Hari.
Okay, ma'am.
So, how you said the whole lot of investigations that you sent for to rule out the infections and non-infections. Tell us in what protocol did you go about checking out what was your differentials for the source of infection and how did you go about ruling them out?
Ma'am, the once the infectious versus non-infectious we have ruled out, ma'am. The infectious causes would be
No, no, no.
uh,
Start with the fact that you had fever on day 3.
yes, ma'am.
What are the possibilities at that point? This is a patient who's had a decompressive craniectomy on first day.
Yeah, ma'am. First day he was done on decompressive craniectomy, and day three he was developed a fever.
So within
Uh,
48 hours of post-operative period,
Post-operative.
you
Yes,
developed
ma'am.
fever. So how do you go about?
Uh, Ma'am, most probably we'll be starting with hospital acquired meningitis, nosocomial meningitis, and aspiration pneumonia, and central venous line is most uh, not
Wait,
very much common, ma'am,
you
because the
said
line was.
once again, you said aspiration pneumonia in a patient who is ventilated. Why will he
Sir,
aspirate?
at presentation, he was his GCS was low initially when he was presenting to local hospital. At the time, when the whole body CT was done, in that there was a minimal aspiration changes was there, ma'am, in lung.
Okay, that's why you're saying it might be a fever which is manifesting 48 hours later.
Yes, ma'am.
Okay, where was this CT finding was on which side?
Right side, ma'am.
Okay, right lung, base of lung, you have features, so you're thinking of aspiration.
Yes,
Okay,
ma'am.
next.
Next would be nosocomial meningitis. Uh,
Nosocomial meningitis within 48 hours of starting
no,
infection.
post-surgical meningitis, ma'am.
Exactly, post-surgical meningitis within 48 hours. Doesn't sound good for your infection control, man.
Probably, ma'am. Uh,
How do you
and,
rule it out?
neck stiffness. Uh,
You said you had tracked him.
yes, ma'am.
Just tracked patient. How will you assess neck stiffness? Your flexion of the neck is limited by the presence of track, and he will definitely have pain if he was off sedation.
Yeah, ma'am.
How are you going
Uh,
to assess neck rigidity?
ma'am, it is little. It was so we have done CSF analysis, ma'am.
Before that, what did you do? So, what I'm
Um,
trying to tell you is in a tracheostomized, sedated patient, clinical signs of meningitis is very difficult to elicit.
yes, ma'am.
So, before doing LP, what do you have to do?
Any imaging,
Correct.
MRI,
CT
CT.
is enough. What are you looking for?
Um, uh, any increased signs of ICP.
Yeah,
Uh,
basically, your LP and the CSF drainage should not lead to a uncle herniation, a
okay, ma'am.
tonsil herniation. So, raised features of ICP should have been reduced compared to the presenting CT. In that case, you're safe to do a LP.
LP.
How
Okay.
you said LP, you had WBC of 100.
Yes, ma'am.
You didn't mention anything about RBCs.
Ma'am, RBCs, RBCs was around 50 cells, ma'am. But in post-traumatic STH patients, it will be little bit difficult to differentiate with RBC and WBC ratio, ma'am.
So,
So,
what are the other factors which are corroborative to say this is bacterial meningitis?
we'll be seeing sugars. Sugars will be low uh,
Mm-hmm.
compared to corresponding blood sugars, and
Mm-hmm.
procalcitonin we can see, ma'am, and lactate.
Yeah, most sensitive now is considered to be lactate. What are the
Lactate.
cutoffs?
Less than 35, it will be non-infective. If it is more than 35,
35 ah.
ma'am,
Lactate 35 ah. You're
ma'am,
talking about serous lactate.
yes, ma'am. In our hospital, that, ma'am,
3.5 or 35?
ma'am, we'll be measuring in mg per deciliter.
Ah, this is the most important thing.
Yes,
Unit.
ma'am.
I knew you were
Yes.
going to say that. Yeah.
So, in our hospital, we'll be having a cutoff of around 35, ma'am.
Mm.
Uh,
Procal?
Ma'am, Procal point 5.
Mm. Point 2 to point 5.
Point.
The literature says different things.
Okay,
But
ma'am.
these two are supposedly more sensitive than the other
Other,
conventionally considered parameters of CSF.
okay, ma'am.
Okay, go ahead.
Ma'am, all the reasons for ma'am, other infectious causes like central venous catheter and urosepsis and surgical site infections and intra-abdominal any sinus evaluation have all these things have been ruled out, and non-infectious causes are like DVT, pulmonary embolism, uh, acalculous cholecystitis. These things have been ruled out. So the probability of central fever can be considered.
Yeah, so central fever is a diagnosis of exclusion.
Exclusion.
All the infective causes have to be ruled out before you start thinking of central fever. Carry on.
Uh, the patient was started on tablet bromocriptine, uh, 2.5 mg Q8 hourly. In view of persisting fever, it was increased up to 5 mg 8 hourly, ma'am. Gradually, in subsequent days, the fever have been subsided and weaning attempts were made, and patient was weaned to BiPAP on day 9. And passive mobilization with limb physiotherapy was initiated on early days and continued throughout the stay. And patient was shifted to step down ICU by day 13. At present, patient was in step down ICU with a GCS of E3 VTM5, moving all fold, no deficits, was on BiPAP support with BiPAP of 12/6 support.
Why didn't you consider VAP as the cause? You
Ma'am,
already had a patch.
yes, ma'am, we have seen X-ray, ma'am, in that there is no new infiltrate, ma'am, and secretions were also uh, not that much purulent, uh, and there was no endotracheal aspirate was done, sent, ma'am, but it turned out to be negative. Uh,
Two things. One more clinical factor which would you consider to rule out VAP? You talked about X-ray, you talked about color of sputum. One more.
uh,
Did your oxygen
PF,
requirement go up?
ma'am, PF ratio and FiO2 requirement and hypoxia is not there, ma'am.
And
PF
then
ratio was,
you said you send the endotracheal aspirate.
yes, ma'am.
What type of culture do you do?
Ma'am, ma'am, we'll be sending,
Quantitative or semi-quantitative?
ma'am, semi-quantitative, ma'am.
So how much organisms were there?
No organism, ma'am.
So your culture showed no growth.
Yes, ma'am.
Smear?
Ma'am, no growth, ma'am.
Smear also showed no growth.
Yes, ma'am.
Usually your smear comes and that gives you a very brief idea about what type of organism you are going to deal with. That gives you around 24-48 hours of time to start an appropriate
Yes, ma'am.
empirical antibiotic, followed up with culture when you can upgrade or de-escalate.
Yes,
So
ma'am.
your smear was negative and your culture was also negative.
Yes, ma'am.
Your take on tracheostomy to reduce VAP, you did an early tracheostomy.
Yes, ma'am. On day 4,
So you said it was, what was your aim of tracheostomy?
ma'am, to facilitate weaning, ma'am.
Yeah, why not about reducing VAP?
Yes, ma'am. That is also, ma'am,
No.
more or less, VAP will be same in tracheostomized or early
Correct.
tracheostomy versus late tracheostomy. There is no difference of VAP, ma'am.
What type of suctioning do you use?
Ma'am, open section, subglotting, ma'am.
Is there any value in going for close circuit suctioning?
No, ma'am.
Why is it advocated?
Uh,
The advantage of closed system is not to reduce infection. In fact, it is to reduce the aerosolization during the suctioning.
okay,
For
ma'am.
the patient, there is no benefit, no reduction in VAP rate. But for the neighboring patient, the spread of infection, aerosolization is less. And to yourself also. Understood?
Yeah,
That is the reason why it is advocated. What are the other VAP bundle?
ma'am. Head and elevation,
Mhm.
then uh, chlorhexidine mouthwash uh,
Mm.
every eighth hourly, uh, and frequent suctioning, ma'am.
Okay. And one more thing is frequent sedation hold.
Yes, yes, ma'am.
And see if you can
And
wean from the
ulcer prophylaxis, ma'am. Uh,
and you can wean from the ventilator or not.
Ventilator, daily weaning attempts.
Then you dealt with UTI. Now, how do you deal with UTI? Very common. What is the incidence of the various infections in neuro ICU? Which is the topmost?
Ma'am,
Nosocomial?
VAP, ma'am.
No, it is UTI.
UT.
You
Okay,
will
ma'am.
be UTI the most in neuro ICU, followed by VAP. So, how do you take care of UTI? How can you reduce? You have two things. One is you have to reduce the UTI, and second, you do not have to overdo antibiotic treatment for UTI. So, how will you take care of these two in neuro ICU?
Ma'am, frequent handling should be avoided, ma'am.
Mhm.
Uh,
I give you
and
one scenario. Your
it should
patient
be
came from,
uh,
I'll just give you one scenario. Your patient
okay,
came to you
okay, ma'am.
hospitalized from somewhere else.
Okay, ma'am.
He's intubated somewhere else, he's catheterized somewhere else,
Yeah,
and
ma'am.
then comes to you.
Okay.
What are the precautionary measures you're going to take to prevent infection?
Ma'am, we'll be changing the new catheter, ma'am.
Does it help?
Uh, Ma'am, no, ma'am. It is
Let
not
me-
going to help or prevent CAR-T, ma'am. But
What else can be done?
urine complete analysis to be done uh,
Yes.
to see whether there is any infections.
Yeah. So do not start antibiotic
Things.
empirically unless you have sent a urine routine. And
Okay, ma'am.
unless your routine is suggestive, you do not start. Because otherwise the chances of colonization is very high because our patients are going to be on catheter for a long time.
Yes,
You'll end
ma'am.
up using antibiotics unnecessarily. Other things are ambulate the patient as soon as possible
Yes,
and see if
yes,
you
ma'am.
can get rid of the catheter.
Yes, ma'am.
What about central lines?
Ma'am, if the patient is coming from outside hospital, will be retaining the central line if until unless there is any requirement of vasopressor, any hemodynamic instability, will be retaining the blood culture, ma'am. But we'll we'll see the clinical scenario and we'll take a decision, ma'am.
Okay. What lines do you prefer in order of preference? Which are the
Um,
site of lines?
Subclavian is first preferred one, ma'am. In our ICU, we'll be going ahead with subclavian, and
Why do
then
you choose subclavian as first?
the rate of infections is less, ma'am, compared to
The
jugular
chances of
pneumo.
injury is more, no?
Ma'am, yes, ma'am. The chance of injury is more, ma'am, but we'll be going ahead with the ultrasound guided only, ma'am. Uh,
Okay.
so probability of injuring any artery or pneumo is
So basically, necklines either subclavian or
uh,
jugular. Literature says
jugular.
jugular first, subclavian later, and then femoral.
Okay,
So
ma'am.
that reduces. What else?
Uh,
What is the central line bundle?
ma'am, ma'am, chlorhexidine dressing. Uh,
You use all the
ma'am,
sterile techniques for
yes,
inserting
ma'am. Inserting.
in chlorhexidine dressing.
Yeah, ma'am.
What about
And
the hubs?
daily checking of the insertion site.
Mhm,
Uh, then daily review of line, ma'am, and
mhm,
proper catheter hub care.
mhm.
Uh, and
First and foremost, every rounds you see if you can get rid of it.
yes, ma'am.
So, what are the common reasons you retain central line in neuro ICU?
Ma'am, hyperosmolar therapy, ma'am. Either uh, mannitol or the 3% saline. Uh, for that is the one. That is the major reason for
How
central
many
venous.
lumens do you need to give that?
Ma'am, ma'am, will be go in our ICU. Will be following with a three lumen central venous catheter, ma'am.
You said you have most of the time you what you need is hyperosmolar therapy. That
Yes,
can be
ma'am.
administered from one lumen. Then why
A
do you
single
need three
lumen.
lumens?
Uh, okay, ma'am.
Do you know of any other this type of central line with one lumen which can be kept for longer time with lesser infection?
PIC line, peripherally
Correct.
inserted.
So most of the indications for which we keep central line can be met with PIC.
Okay, ma'am.
So that gives you a very safer alternative as compared to other centrally inserted cannulae.
Okay, ma'am.
Um, yeah. Then one you said took an example of TBI. So one cohort of patients we haven't discussed at all is post-op patients. So post-op patients, post-neurosurgery patients may have high spiking fever from day one. How do you know this is not an inflammation and this is infective? How will you differentiate?
Ma'am, ma'am, relative bradycardia will be there in non-infectious patients, ma'am.
Why?
And ma'am,
DVT will cause bradycardia.
no, no, ma'am. Sorry, ma'am. I got confused, ma'am. Uh, okay, ma'am. The POD one, any hemodynamic instability, uh,
Basically, you will not have any serological marker as such to tell you whether it is infectious or non-infectious. You have to go by the clinical
it's in.
scenario.
Yes, ma'am.
Usually, day one post-op fever is inflammatory causes, and
Okay,
you
ma'am.
may not cause much of a hemodynamic instability. So you may
Oh,
not need to kickstart any antibiotic for that.
okay,
Also
ma'am.
important is to know the type of brain tumors which will cause aseptic meningitis.
Okay, ma'am.
Okay. So think most of the cystic lesions like epidermoid or craniopharyngiomas, these are very likely to cause seepage of the fluid, sometimes aneurysms with seepage of blood. These can cause fever. Like central fever, these are also one of the causes for non-infectious fever. What you have to do is only symptomatic treatment. You may
Okay,
not need to start antibiotic. And
okay,
the
ma'am.
incidence of this is much higher in pediatric.
Okay,
So
ma'am.
pediatric, you get so worried, you invariably give antibiotic when it is actually not needed.
Okay, ma'am.
You haven't spoken about the need for steroid in meningitis. When do you give? When do you not give? What are the precautions you have to take with that?
Uh, ma'am, ma'am, in only in community acute pneumonia, there is a role for steroids, ma'am. Uh,
Okay.
there is a no role for steroids in nosocomial hospital acute meningitis, ma'am.
When do you start?
Ma'am, before administering antibiotics, ma'am.
Mhm. How much and for how many days?
Ma'am, Dexa will be given uh, 10 mg Q8 hourly for
Per
around,
kg, how much is it?
ma'am, per kg,
4
uh,
mg per kg for 4 days.
okay, ma'am.
The high dose compared to what we give as an
Okay,
anti-edema measure in tumors.
okay, ma'am.
But it has to be given before the antibiotic and
Antibiotic.
in
Yes.
community acquired. Why is it given?
Ma'am, to penetration of antibiotics will be but
Hmm. No, 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 no.
to reduce the inflammation and
The sequelae of meningitis will be reduced. The
yes.
usually inflammatory changes is what results to cranial nerve damage and vasculitis. To reduce that, you do use the steroids.
Okay,
Okay.
okay, ma'am.
Okay, what else? Okay, suppose in your patient you started feeds on day 2.
Yes, ma'am.
Uh, After 24 hours of feeding, if you were to start the fever
Okay.
and with loose stools, what will you take measures?
Uh, Ma'am, we'll see the consistency of the stools and color, any foul smelling, we'll see, and whether think any diarrhea causing fever, uh, most probably C. diff.
Yeah, so you have to look for the history of antibiotics, the CD for possibility. What symptomatic measures will you take soon?
Ma'am, isolation, and we'll send a stool for C. diff toxin A and B.
No, what I
Uh,
meant was with the diet, what can you do? How can you monitor the
Ma'am, peptamine based feeds.
Mhm. You were giving almost 2 gram per kg of protein. Would you want to
Yes,
alter
ma'am.
that?
Yes, ma'am. We'll be reducing the, that's what, ma'am, we'll reducing the protein to 1 gram.
And if it is milk-based protein, you can reduce that.
Okay, ma'am.
What is your opinion on bolus food versus continuous food? Continuous feed?
Ma'am, more or less, the feed intolerance was less in compared to bolus versus infusion, ma'am.
There's not much difference, but when you have a condition like
Okay.
this where there is loose stool and fever and you don't know the source, which
Okay.
could be related to nutrition, you may have some positive by giving continuous feed rather than bolus because one huge amount of feed when given, intolerance is likely to be high.
Yes, ma'am.
Yeah, that's it. DVT you already spoke, no?
Yes, ma'am.
What about your patient was how old?
I'm 35 years old, ma'am.
Suppose he was a 20-year-old
Okay, ma'am.
and he had diffuse axonal injury
Okay, ma'am.
and had spiking fever from day 5 onwards.
Okay, ma'am.
Posturing and tachycardia, tachypnea.
Okay, ma'am.
What would your probable diagnosis be? How will you manage?
I'm m- most probably in young age compared with the diffuse axonal injury, most probably it may be parasympathetic hyperactivity. Uh, according to the clinical things, it may be parasympathetic hyperactivity, ma'am. Will be managing with propranolol 10 mg Q8
How will you
hourly.
deal with the fever there?
Ma'am, bromocriptine and propranolol also, in some patients, propranolol also will help in reducing fever, ma'am.
Mhm.
Some,
What are the other things for other than bromocriptine you can use for central fever?
ma'am, propranolol and the baclofen can be used, ma'am.
Baclofen will be more useful for the
Uh,
spasms or the
yes, ma'am.
posturing. For
Posturing.
central fever, you could
Then
use
amityl,
naproxen as well.
and yes, ma'am. Naproxen will be using, ma'am.
Yeah. Um, have you dealt with medullary tumors?
Ma'am, yeah, ma'am. Few cases.
So in medullary tumors, you may have uh, eye spiking fevers with very, very high hyperventilation
Yes,
and
ma'am.
rising lactate.
Okay, ma'am.
That is another cause of
Okay,
central fever
okay,
and
ma'am.
central hyperventilation. The
Okay.
hyperventilation is not proportion to the fever.
Uh, okay,
So
ma'am.
you will have CO2s of 16, 15 with pH of 7.67
Yes,
and all.
ma'am. Yes, ma'am.
But
Will be.
hyperventilation is not because of the fever, but from the medulla.
Yes, ma'am.
And the tumor per se will release substances which
Okay.
cause uh, anaerobic metabolism and cause lactates to rise.
Okay, ma'am.
There, controlling the fever alone may not settle.
Yes, ma'am. Will be using morphine or any
Yeah,
opioids.
yeah.
Uh,
Um, I think, oh, one last thing. Now, since we're talking about fever, if you had ACBs as your causative agent in the CSF, how are you going to treat?
ma'am, ma'am, I didn't get you, ma'am.
Acinetobacter, sorry.
Yeah, ma'am. Ma'am, we'll be treating with intrathecal colistin uh, plus IV colistin, ma'am. If needed, we'll add a TG tigecycline with colistin, ma'am, intrathecally,
What
depending
are
upon the.
the agents that can be given intrathecally?
Ma'am, we have given intrathecal colistin plus tigecycline we have given, ma'am. In one patient, we have given, ma'am, in one.
Open to the forum. Can anyone answer what all drugs can be given intrathecally? I mean, antibiotic wise. Colistin is one. What else? Okay, Harry, what is the problem with giving colistin intrathecally? What are the harm?
Chemical meningitis can
Mm-hmm.
be seen, ma'am.
Then
Uh,
it can cause neuritis.
okay, ma'am.
You will not know is it the complication of colistin or is the drug not acting and neurologically he's worsening. You may not have any clue about that. How
Yeah, ma'am.
about polymyxin?
Ma'am,
Polymyxin can also be given,
yes,
and
ma'am.
age-old Genta can also be given
Ma'am,
intrathecally.
for one patient, we have given Genta, ma'am.
Yeah, gentamicin can. That is what started first. Colistin and all is much more recent drugs. In the older times, if you had to give intrathecally, it used to be Genta. Um, so suppose you started intrathecal and you
Okay, ma'am.
want to know whether the patient has improved or not. Someone with meningitis will be obtunded, say a GCS of 9 by 15. For GCS to improve and for him to recover and you to realize that your treatment is working will take long time. So in the meantime, how do you know whether your treatment is working or not?
Ma'am, will will do CSF analysis uh, after 7 days. We'll be doing a repeat
You
CSF
have to
analysis.
wait till 7 days?
Ma'am, by third day we'll be doing, ma'am.
Yes. So CSF clearance will start occurring as soon as
Yes,
3 days.
yes,
And
ma'am.
if in 3 days' time you are not seeing any improvement or rather worsening, then probably your choice of antibiotic is not correct. Or maybe you are dealing with some other organism other than bacteria also.
Yes,
The
ma'am.
other thing is, suppose you diagnose meningitis with your lumbar puncture and CSF from lumbar area. Now you
Okay.
have put an EVD
Okay,
and
ma'am.
you're taking the CSF sample of the ventricles.
Okay,
Will
ma'am.
both the parameters be the same?
Yes, ma'am.
No. Can anyone answer me this, please? We've discussed it last time also. I think Adira is in the group. Adira, you may speak up. Okay, I'll rescue.
Okay.
So the as you poke for CSF sample,
Okay.
gravitationally lower, the
Okay,
CSF,
ma'am.
the WBCs tend to settle down. So you
Okay, ma'am.
may have a higher WBC count in a lumbar puncture as compared to a ventricular sample. So
Okay,
this is
ma'am.
a very common fallacy. You may
O-
think that your antibiotic is not working when actually it might be. You have to keep in mind where you have first poked and where you are
Okay.
taking the second sample from.
Okay, ma'am.
Okay.
Okay, ma'am.
I think I have covered everything. Dr. Gopi, are we missing on something?
We have covered most of it, ma'am. Like we use for WAP, we understanding the limitation of the CPA score, ma'am, clinical pulmonary infection scoring systems. We use CPI, ma'am. If it is more than six, along with the other parameters, if the probability is pretty high, then we start initiate antimicrobials, ma'am. Now, we use quantitative cultures in our setup, ma'am, rather than semi-quantitative cultures. And regarding VAP prevention bundles, like of late, recently they have excluded this chlorhexidine, ma'am.
Yeah,
It has
yeah.
found to increase incidence of tracheitis and even morbidity, even mortality is also known. So they have eliminated from the bundle now, chloroxyl mouthwash. We have stopped using chloroxyl mouthwash in our ICU. Ma'am.
Ma'am, nowadays we are not using, ma'am, with
So one more question for Hariharan, Hariprasad.
ma'am.
VAP is another leading cause of infection in neuro patients, especially neurology patients who are going to stay in the ICU for long. Like
Yes.
myasthenia, sometimes it is 3 months, 4 months stay.
Yeah, ma'am.
Do you prevent long-term VAP complications in neuro ICU? Something came up in NEGM recently.
Ma'am, early isolation.
No. What is SDD? Selective digestive decontamination. This
Okay,
is
ma'am.
an old tablet come in a new cover. It's been on for some time,
Yes,
but
ma'am.
now they have
But
looked at it again. And the problem is, it started with the medicines like erythromycin, tobramycin, and all, and now they say even meropenem should be given as a prophylactic agent. And nobody can vouch for increasing resistance or loss of sensitivity with indiscriminate use of antibiotics. So it depends. If your ICU has very high VAP rates and you're losing patients to VAP, then you may consider it. But
okay,
otherwise, there is no guideline which can tell you. It does have some value, but cannot be practiced everywhere. Depends upon what isolations you have in your ET aspirates and how burdensome is VAP for you.
okay,
They have also
Gobi,
tried SDD for pancreatitis patients, ma'am. Like we tried initially, ma'am. Like somebody, as you said, like in ICUs where the prevalence of resistance is pretty high, more than 10%, it is better to avoid SDD, ma'am. Basically, they try to eliminate gram positives, gram negatives, except anaerobes and even fungal elements, ma'am, with
Mhm.
topical antifungal and antimicrobials, ma'am.
Yeah,
Uh, in if your prevalence is less than 5%, obviously you can try, ma'am. But no, in India, obviously it can't be, ma'am.
nobody. I don't think I've not come across anyone who's been using it.
Our prevalence of XDS is close to 15%, ma'am. So
Mm.
we generally avoid SDDs in our institute, ma'am.
Anyone in the group has anything to clarify? I didn't see anything in the chat also.
Ma'am, regarding lactate and procaine, post neurosurgical meningitis, ma'am, to rule out aseptic meningitis versus bacterial meningitis.
Mm.
What cutoff do you adhere, ma'am, for Procal and lactate, ma'am?
It is still not there in our biochem panel. We, according to our need, we send, no, not for all patients, only when it is, we are in a dilemma whether our treatment is working, only then we send. And we take 3.8 as a cutoff. Our units are different, of course.
Okay.
So in your units, it would be 38. That is what we take as a cutoff. But I think JIPMER has in its initial CSF biochemistry panel itself, they give.
Okay.
I don't know what is the cutoff they are using.
Now, regarding surface cooling devices, ma'am,
Mm.
your take on surface cooling devices. Obviously, antibiotics, like most often, doesn't settle the temperatures, ma'am.
Mm.
We
Surface cooling, it is very easy to get the temperature down with surface cooling, but it is very difficult to maintain. And when you're stopping it, the controlling the rate of rise of temperature is also very difficult.
okay,
In our experience, we don't have IV cooling system.
okay,
We
ma'am.
have only surface cooling. So inadvertently, when you stop, the rise in temperature is too high. That is more catastrophic than uh, pure hypothermia. So we seldom use.
Okay,
But in Western world, when you use IV cooling measures, it is wonderful.
okay,
But then outcome measures have not improved. As of now, in the guidelines, it stands as a very low evidence. If you want, you can practice. Like in spinal cord injury about the steroids, if you have good experience then and you've had good results, you may. But no one can sue you for not doing it.
okay. And most of them, we have seen patients do develop VAP, ma'am, particularly when being subjected to hypothermia TTMs
Mhm.
for post-cardiac arrest patients, ma'am. Like invariably on day 3 of TTM, post-TTM, ma'am, like these patients do develop VAP, ma'am, but they do recover.
Mm. Anybody in the group wants to clarify anything? See, the exam goes hardly any time left. These topics, I'm sure you're not going to touch again. And in the long cases, this will be asked. So if is anything bugging your mind, please ask. If not, we'll say goodbye. I think our next class will be in January second week. We have next week, we have a very interesting journal club. Dr. Babu Ibrahim is taking. Please make sure you attend it next Thursday.
Okay, ma'am.
After that, we will have Christmas and New Year to celebrate and come with rejoiced and renewed vigor to learn. So see
Okay.
you. See
That
you
was
again next week.
Thank you.
Thank you. Bye. Good night.
Bye.